Our next speaker is Dr. Sanja Dacic. She's a professor of pathology at the Department of Pathology of Yale School of Medicine. She's also a vice chair and director of anatomic pathology of the Department of Yale School of Medicine. Notably, she's also our current chair of the ISLAC Pathology Committee.
All right. Good morning, everyone. Thank you for coming. And before we dive deep into issues, I would like to thank the organizers for a very kind invitation. It's really great to be here. And you know, when you get the invitation, you get excited. You're going to a new place. You're going to meet new people. You're excited about a topic that you got. And that's, of course, 6 months before you have to put the talk together. And then, you know, a couple of months ago when I saw the title, I was like, what am I going to talk about? And actually, I decided what I'm going to talk about, and we'll have a journey of 15 minutes to painful aspects of pathology that I'm sure many of you in this room have no idea that they're happening. So let me make you aware. These are my disclosures. This is official learning objective. My objective is actually to tell you about the problem that we have. And you know that saying, Houston, we have a problem. I'm saying Montreal, we have a big problem. And I want all of you in this room, after this presentation, when you go back to your practice, to never read a pathology report with the same eyes. So that's my objective. So why am I talking about this? And I'm like so excited about this as a pathologist. I know everyone in this room knows all these curves about major pathologic response and about pathologic complete response. We're even not going to go into definitions because that's an issue as well, but that's for another topic. But you can see that their numbers are variable, and you know, everything is kind of associated with basically drug effect. But there are many other issues that can actually contribute to these different numbers, and I want to make you aware of those. NPR and PET-CR are not only in the neoadjuvant IO trials, or now basically as a standard of care in a practice, but they are also going to be used as kind of like endpoints in basically biomarker-driven neoadjuvant trials. So they're basically becoming a very important piece of how we are reading the trials and what are we going to do in a practice. And a few weeks ago, you are all probably aware of NeoDaura trial that was presented at the ASCO, which also used NPR and PET-CR as the components and endpoints of the trial. So why am I talking about this? Because lung cancer is not a breast cancer, and neoadjuvant treatment for pathologists is actually new in a lung cancer. And actually, we have more problems and more questions than the answer at the moment. So in contrast to breast cancer, we don't have a standardized approach to grossing. We don't have a standardized approach to histological assessment of NPR and PET-CR. We don't know how morphology, or actually we are learning right now, how morphology looks in a different settings and different types of the neoadjuvant therapy. As you know, in the literature, we had the different scoring systems. And always is the question, well, pathologists are reading these, how good are they actually, and how reproducible is what they read? And those questions were addressed, I can't believe, almost 5 years ago in 2020. And ICLC, it was a multidisciplinary effort primarily led by the ICLC Pathology Committee, tried to put some sort of recommendations because everybody knew what was going on in the clinical trial world, but we knew this was coming in the real world. And what is in that trial is actually all based on all studies, all trials, chemotherapy trials from 90s and 2000s. And actually most of the statements there are based on the expert opinion and experience of a pathologist as well as our clinical colleagues. The first thing when we are talking about neoadjuvant specimen and their processing actually in the pathology laboratories is that we need to know, pathologists need to know that patient was treated with a neoadjuvant treatment. And the reason for that is that if we don't have that information, we actually cannot tell whether there was a neoadjuvant treatment or not, because the same changes that we see in the neoadjuvant specimens, we can see in actually treatment-naive specimens. So we need to know. And I'm sure every one of you in this room had a case of patient treated with neoadjuvant therapy that basically got the report as treatment-naive, without YP staging, without adjustment of the, I know you do. So never happens in Canada. Yeah.
The surgeons are very good.
Yeah. So anyway, in States it happens quite a lot. So that's the first thing we need to know. And it's important to know because then we actually give you the right staging of these patients, because staging is actually based on a microscopic tumor size, or it should be based on a microscopic tumor size or residual viable tumor. But I can tell you that I can still see the reports with basically YP stage is based on a gross tumor size or tumor bed size, and it's not adjusted for the viable tumor. We also have an issue with the lipidic component, and we are kind of arguing what to do with that, but that should be subtracted, and probably we should follow the 8th or 9th AJCC staging criteria. So there are many issues for the clinical practice. So now I'm going to get you into nuts and bolts of basically pathology and tell you what the issues are, but I don't want you to be scared because what I'm going to present is going to be scary. So, grossing protocols. When we are dealing with tumors that are less than 3 centimeters, equal to 3 centimeters, we're supposed to submit that entirely. And I would say compliance is pretty good in a pathology practice, so we can pretty much feel comfortable with the tumor size up to 3 centimeters. Once the tumor bed is greater than 3 centimeters, we are all over the place. According to ICLC criteria or recommendations, we should entirely submit the largest cross-section of the tumor bed and then 1 additional section per centimeter of the tumor. And this pretty much recapitulates what we do in the sarcomas and in breast, essentially. So, but this is where we see the most of variability. So what happened in a neoadjuvant or perioperative trials in terms of the grossing protocols? I can tell you this was the most painful table that I needed to put together, because when you read the papers and you try to figure out how pathology was done, in material methods, there's a paragraph, pathological assessment, and then go into supplementary material. So then you go into supplementary material, you're trying to find it, and what's in supplementary material is actually the entire clinical trial protocol, which is about 200 pages. And then on page 147, there are like 3 sentences about how this was done. So I tried to figure out how this was done, actually, and this is really no preference why I picked these trials, but, you know, it's like I could actually be able to find something. So essentially, some of the trials do follow the recommendation of the ICLC. Some of the trials use a 6 centimeter tumor size when they decide whether to submit everything or not. And then some others basically said every 3rd section of the largest diameter is okay. Then some said just follow the institutional guidelines. And I have to say, basically, we don't have a guidelines in thoracic pathology how to process those specimens. So what are these guidelines? It could be between 2 sections and 35 sections, 100 sections, so it's all over the place. So we have to standardize this because this is a true issue. And MD Anderson group actually tried to put together all of the grossing protocols that have been published, or kind of the most frequently used, and tried to come up with a recommendation that we all should follow, and basically recommended that we should submit the entire tumor bed, regardless of the size, and this is what I'm doing in my practice, and I can tell you I'm not the most popular pathologist. And basically they said, let's go with up to 20 sections, and they provided a reasoning for that, which is quite similar actually what we are doing in the breast, or our breast pathologists are doing. They're not submitting more than 25 sections. And they'll live with the fact that basically there still might be some viable tumor in the tumor bed, and they just live with it. But there could be the reason why actually PET-CR or pathologic response is never going to make actually into the biomarker in the breast cancer. So, okay, so this is our grossing, which is a mess. Then we have a microscopic examination, which is another mess, I would say. So basically there are 3 different ways how we can do this. And there's no way that in a clinical trial you can actually figure out how it was done because nobody actually pays attention to it. So we believe that most common way is informal or semi-quantitative or eyeball approach, because that was used in all chemotherapy early trials. And it basically showed that MPR does have a clinical relevance. But the major critique is this is like a crude, this is subjective, but we as a pathologist love it because particularly for us who are thoracic pathologists, we can do this very fast, even if you get 100 slides. But then everybody criticized this is not good enough, we have to be better, and then came up with the proposal to do the slide average, which is basically you document the components of the tumor bed, viable tumor necrosis, stroma for each slide, you divide by the number of slides, and you get a number. But then the critique was that basically this does not take into account that each slide has a different amount of the tumor bed sample, so therefore it's not good enough. And then a few years ago, the most painful approach was suggested, weighted approach, or so-called NPR calculator. So what I think is, it's basically Excel formula, and what we are asked to do, and some of the trials are actually using that, is that on each slide, pathologists have to measure the size of the tumor bed, and you can imagine if you have 7-centimeter tumor, you can get quite a lot of slides to measure the size of the tumor bed, estimate each component of the tumor bed in that Excel spreadsheet, and then it's going to give you this slide average as well, what is called a weighted approach, which basically takes into account proportion of the tumor bed on each slide. Extremely painful, extremely painful. So what was done in the clinical trials? Again, for many, we actually have no idea how it was done. We suspect it was eyeballing. Some actually, NeoStars said it was a slide average, but majority actually we don't know how it was done. And we really have to get that under control as well, because I'll show you in a minute why it's important. So one of the questions was, which one of those three methods is actually the best? We as a pathologist, of course, would like eyeballing because it's fast and easy. And the ICLC Pathology Committee actually did a reproducibility study to also answer the question whether pathologists can do it in a reproducible way. And we did it both ways. We did it weighted and the slide average, and they actually demonstrated that these two methods go pretty much hand in hand. So, of course, it's a limited number of cases, if you will. It was like 89 cases, if I'm not mistaken. Slides per case range between 30 and 37. And this was all done by thoracic pathologists. So you have highly subspecialized pathologists who pretty much know what they're looking at. So no wonder you are getting quite close results. But then when we looked actually closer into the assessment of the NPR, and we are looking into the percentages of the viable tumor, even though overall we are doing very well as a pathologist, particularly at the extremes when we are talking about complete pathologic response, and this is where I, as a pathologist, if the sample is entirely submitted, feel very comfortable, and I think you have to also feel comfortable. We are able to recognize whether there was a tumor or not. We are doing great. We are also doing great when we have like more than 95% of the tumor. So those extremes, we are really good at that. But when you get down to basically 30 to 60% of the viable tumor, actually curves separate, and we as a pathologist are actually underperforming. So if we are thinking about NPR and different percentages of the viable tumor to use in a practice to guide whatever you are going to decide in the management of the patients, we really have to sort this out somehow. So, and this is just one example of a recent case that I had, but it can actually show that there could be difference between different methods and how this can actually impact the staging. And it always comes when you're dealing with the big tumor beds. So essentially, tumor was a 7.2 centimeters. It was treated with the chemo IO. And basically, I did these like hundreds of slides, looked into it. So basically, my weighted approach or NPL calculator resulted in 75% of the viable tumor. Slide average resulted in a 70%. So then you're supposed to adjust basically tumor size. By one method was a 4.4, by the other one was a 3.9. So it's a difference. So this will result in a different YPT, T2B versus T2A. And this case had the negative lymph nodes. So actually, it will have an impact whether it's a 2B and a 1B. And it's important to know if we are going to use this in the future in the management of the patients, we really have to sort this out. If the lymph nodes would be positive, it wouldn't matter because we know the lymph nodes drive the staging and behavior of those tumors. But if lymph nodes are negative, we do have a problem and we have to sort it out. So my take-home message is that interpretation of clinical trial data and protocols as currently they stand is quite challenging. And what worries me is when I see numerous meta-analyses now coming out, comparing those trials and making statements of pathological response when actually methodology was quite different, or we even don't know what the methodology was. I'm very worried as a pathologist if what I put in the report as a pathologic response will inform any treatment decision, whether the number that I put down is going to result in escalation or de-escalation of post-operative therapy. So in order to calm your pathology colleagues, particularly your thoracic pathologists, we need to standardize pathology grossing protocols and microscopic examination for all clinical trials as well as for clinical practice. And I think it's a multidisciplinary effort. And I'm glad that we are at this conference, so I hope we are going to have time to talk about it. So thank you so much.
Wow, that was amazing. Thank you, Professor Dacic. I am completely terrified, thinking that you guys live in this temple of truth, and now I know what really goes on. It seems a little bit like the operating room. All right.